Your kids are soft. You lack discipline.
We landed on the moon!
You didn't earn the knowledge for yourselves, so you don't take any responsibility.
I thought we've forgotten who we are. Explorers, pioneers.
Who knows? I can't see.
Hello in there.
That DNS class you posted about seems...
Yeah. What was it? Neurologic. approach to
Nana.
Athletics.
Yeah.
What is it?
Nana.
That's what I thought at first. And then, like, I
That's
had
what it
to
says.
read the description.
Joyce.
It says DNS Nana about Joyce.
Yeah, that class looks cool, except it's just Rich and Brett. Who's the third?
It starts with an M. Mode. G-Shiva.
But it's in Napa, so they're just going to drink wine.
Yeah.
It will be cool. I'd like to go drink wine.
Well, that's fine. When I saw where it was, I sent it to Katie and said possible trip question mark.
Yeah. Well, talking about DNS, that's going to be the, I was going to say flavor of the day. I think I've been watching too much Guy Fieri. You guys, Alana, Kovasova. That's not obviously Alana. That's
I was about to say, I was like, man, that's an A and that's definitely a K.
So it should be cool to get in there. That's basically who, I don't want to say, well, whatever, is basically running the rehab, like Prague school at this point, because Pavel's just off being famous. But we are talking about DNS. Any hot topics? We were just talking about how great of care my kids got at the nurse practitioner, which we'll just leave that for behind the scenes. We had a patient that went to their primary care and had magical palpation skills.
They had abdominal pain and bilateral anterior hip pain, and their primary care touched their like spinous process of their low back and goes, "Yep, you're having muscle spasms," even though she could do like no back pain, full like toe touch extension, and like, yeah, never once felt her back.
But I mean, that's maybe were they a DO?
Nah, I don't
They had
know
to
that.
palpate a piece of hair under 200
I don't
telephone
know.
book
I mean,
pages.
the mammillary skills have gone, but
Mammalitis.
yeah, mammalitis.
Mammalitis. Any updates on any other previous patient stuff?
I mean, I guess the one that I haven't shared
Scooch
about.
up a little bit there.
The one that I haven't shared about, and I actually just got off the phone with him, where he, like every now and then something will come up, like with his neck and his upper back. Me and Beau both have treated him in the past, and I just looked at him last visit, and I was just like, "Hey, I just want you to get an MRI. No, I'm not scared about anything, and but just to further explain everything that's going on." And then he did, and then you could see the right neuromuscular fragment like narrowing, and I was like, so this one is like when you get in a difficult jiu-jitsu position and you're just doing that for fun, and then you have all the stuff going on your right side, and then it's like he's listened to Rentala, listened to like Atia, listened to all the DNS stuff, and then it's just got me, I just get to re-preach it all.
Yeah, which is usually our job because we don't know anything. We just happen to be in Birmingham, so just echo chambers of other people. Any other updates?
What was the last one where me and you?
Scooch up on these mics, bros.
I'm at the edge.
You could straddle the edge.
Or you could come around a little bit, or you could bring this to you, or you could just hold it like you're singing.
So we had what? I don't even remember what cases we did.
Last one we did was the LCL.
Oh, that's
yeah.
right. I have not seen mine since then.
Mine comes in
She's
next week
running-
for like the 1 month.
Okay.
Actually, she did. She raced a trail half marathon.
Hmm.
She did great on. I also treat her husband, and her husband did really well in the race. And he said it's a pretty tame trail, but I rolled my ankle a couple times, and when I did, I went, "Oh, my wife's in trouble." I think she fell twice.
I think he's rolled his ankle like once a month
Yeah,
for the past 2
he's
years.
been well, and it was one of those. He goes, "I just rolled it, and I kept
do
going. It was
anything.
fine. It wasn't like the time we saw him last year, hotter than hell."
We just need to send, we were talking about the acute ankle sprain like protocol thing. We just need to send more people like, hey, there's this whole video of bulletproof ankles. Like, it's actually a way that you can probably not do that anymore. Again, what do we know? That's why we're doing a podcast. We can talk about what we don't know. And that's actually the theme of today. So Sloan and I were talking last night. She saw two new gymnasts yesterday. So this one, again, not being my case, I'm kind of giving you the 30,000 foot view. But this gymnast had been working with a PT for the previous 3 months because she was having low back pain. Surprise, surprise with a gymnast. The PT referred her to Sloan. She's just like, she's not responding. She'd also taken, I don't know if she is still currently taking time off, but had taken quite a bit of time off. Nothing was changing. So Sloan's working with her, and, as most things usually kind of go back to like just fundamentals. She's like, okay, let's, end up in 3 months supine, see what she can do. She was kind of telling me she's like, scalloped in her upper back or like super erect in her thoracic spine. And she's like, when I tried to get her to kind of depress her low back into the table, she literally couldn't get like T12 down to the table. And, then someone's like, well, I need her to get her rib cage down, and she just couldn't do it. And, the byproduct of that is she was going into like cervical extension, which is common when somebody's kyphosed in their mid back, but then it's kind of, well, why are they doing that overall? And then someone was kind of going further. She's like, well, I need her to get, that area of her back down because that's like the fixed point. And I was like, well, no, it's not. So this was like, we had probably 30-minute conversation from that point. She goes, what do you mean that's not like the fixed point? So for those listening that aren't familiar with DNS, one of the common themes of DNS is you have a fixed point or a punctum fixum is how, as we go through movement development as a baby, you have to have something as a base of support to then move from. So if a baby is, set down because a human can't do much on its own, it's set on its back. The fixed points are what? So you guys know what the actual fixed points for just, we're saying a supine, let's say 6-week-old.
And you have EOP.
So the external occipital protuberance.
Should be shoulder blades.
Yep.
And then, is it sacrum at that point?
Sacrum. So I always like the analogy, Brett Winchester said it during, I think, the last DNSC that I took, that if the patient was lying on a glass table and we could look underneath at him, that's what you'd see kind of pressed in or like flush against the table. Since someone's like, well, why do we, which is, these are all good questions. And, I wasn't attacking her and she was asking good questions, even though, we're both pretty far into our career. She's like, well, why do we want people to flatten their low back into the table? And I go, well, then you're asking what's the goal of the exercise that you're doing, not the position that you're in. So again, if we take a 3-month-old baby, have they developed a lordosis in their lumbar spine yet? Not really, right? You still have anatomical differences in the shapes of those vertebrae for the most part, but you haven't uprighted yet with gravity to kind of force you into that lordotic curve. So when a 3-month-old is on their back, their spine is relatively flush across the board. If we take any of us and we're at rest in 3-month supine, right? At rest, if that's resting, which it should be, your low back may be in contact, but it doesn't mean it's pressurized into that glass table. So that's flush. So would we have pressure on the top of our hand if you're picturing if somebody's laying on their back and I'm trying to slide my hand under like mid low back? Yeah, I shouldn't be able to get it under there. There shouldn't be an excessive, lordosis or extension. But when we tell people to flatten their back into the table, that's not the fixed point. So Sloan goes, well, wait a minute, T12 is not the fixed point? She goes, what's your diaphragm? I go, your diaphragm is the internal fixed point, but then it needs fixed points like an X, which is off of really your sacrum, right? And your scapula. And then to have movement of your head, which starts with your eyes as a 6-week-old, which is when we first get that first optical fixation, you have to have a fixed point of that EOP to then be able to roll your head around, right? Which then you have another triangle from your EOP to your scapula, kind of a triangle down to your diaphragm from your scapula, diaphragm to kind of the edge of your sacrum, right? Or your PSIS. But that was kind of mind-blowing for her. So she kept going through. She goes, well, then why do we want him to do that? I go, if somebody's in start position, which for those listening, just think child's pose-ish, a lot of the times you can use that to do what? Induce flexion in somebody's low back. You can use it to shut off the erectors or get them to relax. So in that position, when we say where you're supposed to flex, because again, if you laid a 6-week-old baby or put them, knees under them, basically the pose that you'll use for like newborn portraits, right? Tuck their legs up under them, have them kind of laying on their own hands. That's kind of start position. That's why it's called that. They're in flexion. So then you kind of have to start asking, well, what's the goal of the position? Do I want their erector to shut off? Do I want them to be able to flex their low back? Do I want their back to just be in and I'm air quoting, a neutral position? And she goes, well, I wanted her to be able to get T12 down because I knew I needed her rib cage to be able to depress. And she goes, so I just had her do a big inhale and an absolutely full exhale to get her, low back flat. And I go, but in that case, if you're not palpating the difference, which I think would be hard to do, the difference between what your rib cage is doing and your back, you're now watching like parasitic movement, right? Or respiratory coupling. So what I'm saying there is if I just say, hey, take a big exhale, you could just be flexing your low back. So you're still running into, well, I need my rib cage to move independently, right? of my spine, I don't want to flex my spine to use breathing. And that might be why she's in that scenario in the first place. And now you're asking all these chicken or eggs, right? And I'll go back to a hierarchy here. But it was a very good conversation to have, because she's like, well, I just feel like I don't understand DNS well enough to move out of the sagittal plane then. And I go, we don't necessarily need to. And I kind of brought up stuff that you and I have talked about, Alex. I go, so Sloan told me that she's like mildly kyphotic or lumbar spine, not TL junction, like lower lumbar spine, right? And I have this kind of hypothesis that a lot of this has to do with kids being sat up too early. They don't have that lordotic curve formed, and you kind of like literally like fold in your lumbar spine, and now you have to get hyperrect in your T-spine. It can happen for all sorts of reasons. That's just a theory. It could be rotational sports, which this girl didn't do. So I was like, we'll just be a little more fundamental with it. Be almost like FMS or Gray Cook. So if her upper back is scalloped, then we have to ask the question, well, on palpation, can it flex, right? If her lower lumbar spine is flexed, can it extend? So the first question is what? Can it move from a just mobility standpoint? Second is, can they move it then, right? Which is a stability or motor control thing. And then it's load management beyond that. Like that's, and again, too, like, well, it can't be that easy. That's what you're doing all the time. And we make it complex with all the, it's 3 months and 6 months and, afferent input. And again, you can use all that stuff to speed up any one of those processes of help in mobility or stability or whatever. And then I go, okay, so then we have that hierarchy. So then if we said, okay, because she's like, well, I have a hard time, because I was like, if somebody couldn't get that T12 down and they have this scalloped T-spine, like 3 month supine is probably not a good position for them. All right, because I would assume, and I don't know, they probably lack, motor control or stability around the parascapular region, right? That's why they're like that. And that's why they can't get T12 down. So it's like you're like having the body when you're assessing in 3 month supine. All right. So if they couldn't do something in the lumbar spine, don't think it's a lumbar spine issue. Think like you don't have a fixed point above your lumbar spine to probably work from, because your legs and feet aren't on the table.
Because she was trying to.
Yeah, vice versa. So now she's trying to drive her head into the table. So there, you're like, maybe that's a problem. And then vice versa. What if Sloan took her legs, right, while we support, put T12 down, and all of a sudden you see that like her neck, like you should be working on upper quarter stuff, which we would all be like, oh, that's literally a regional interdependence cooked into DNS right there. So then I go, okay, let's create a hierarchy where you're like, because I said in that scenario, I go, maybe you put her in, start position or a modified start position to work on scapular stability or, upper quarter stuff. Because that's where I get kind of lost. I go, okay. Sloan was not under the impression she was correct and like, hey, I thought the diaphragm was the key. I go, it is, but it has internal fixed points, primarily to your rib cage and your spine. So the first thing we got to do is make sure they can breathe, which we all just work on. Like, do they have a decent breathing pattern where we're getting circumferential expansion and not necessarily this apical motion? Cool. Once you've established that, then you have to very quickly do what? Determine, can your rib cage actually move? And then if it can move independent of your spine? So that'd be the second hierarchy for me. So that's why I said, I think it's a flaw to coach somebody with huge inhale, full exhale. Okay, now keep your ribs down, because we don't know what happened to their spine. Versus, go from their head and literally like drive, gently their rib cage down, which if you go to Prague and watch them work, that's what you're going to see is they're going to guide the rib cage down and then kind of watch what happens. Do they go into cervical extension? Do they, bring their shoulders into protraction? Is there a bunch of rigidity? So it's a palpation and it's a, mechanical fix. And then third after that would be, well, now you can start working on, do you want to flex or extend or, whatever. But I think that helped her of, again, we all know the, does it move? Can they move it? Load management. Then it's like, well, can you breathe? However we want to say that, like diaphragm. Rib cage movement is a huge deal because of the diaphragm function. And then independent movement, or that uncoupling of respiratory motor uncoupling that needs to happen. And I just think that like, it took me a long time to figure that stuff out, but I think a lot of that came from me looking into breathing so much and being like, oh, like the independent movement's a huge deal. And then also seeing how much of DNS and Prague is ribcage focused, and all the Mojisheva stuff and manual therapy is largely ribcage. And you guys have seen the ribcage chart. So I wanted to kind of bring that up because, again, here's somebody that's taken some DNS courses, not, as many as any of us, honestly, using the concepts. But then in that scenario, and how this all started with that gymnast was, comes in, has extension-based pain, but also now has flexion-based low back pain. My theory on that was, and I'm not knocking anybody, I bet what she was doing with the PT for the past 3 months, because that's when the flexion stuff started, was how they were load managing a poor motor control scenario. Both parts are flex and extend. So Sloan was like, well, I put her in a Cobra, and when she lifted up, it was like highly lumbar erector driven, right? And she had some pain, and someone goes, okay, let's start over. And, got her to relax her erectors, just use her arms and go into extension. And she's like, the girl said it hurt 10 times worse. She goes, so that seems really facet driven. She goes, the thing that doesn't make sense is, why does it hurt almost as much to flex? And I was like, that sounds like a motor control thing, right? Like, you're not necessarily, because she's had imaging, right? So we have all these things going. We're like, well, we've ruled out, major pathologies. So then it's like, well, what would cause that? You can't shut off your erectors even when you are getting them to relax. Because that's also a misnomer to say, like, we see them on versus like, oh, let's shut them off and go back to extension. Well, they're, probably not. Or can you palpate the multifidus? Obviously, the primary care for our patient yesterday can.
It's impressive.
Yeah. So again, I wanted to bring that up because we had a 30-minute conversation. I think that's got value for all of us in here, people listening as well. And there's a lot of stuff that, I came back from Prague and explained how one of the DNS instructors was like, I don't know how I can't remember who asked the question, but I don't know how they exactly framed it. But basically, what's some of your pet peeves of DNS that you see perpetuated, being taught? And it was agreed upon by all the instructors there from the Prague school. They're like, we don't coach IAP or intra-abdominal pressure. We want to see that occur as an ideal pattern, as a byproduct of proper position, work, reflex, whatever it is. And here was kind of a point of conjecture for a long time. Well, what do you mean you're not going to coach it? But that scenario we just talked about is a perfect scenario. Because what would you have to work on? Breathing, right? But that's not necessarily being like, hey, let's create pressure. And I think there's also a difference of coaching IAP versus letting it occur and then drawing awareness to it, which is no difference than if we took somebody into a hip hinge and we didn't say, hey, we're going to look for hamstring tension. You get into a hip hinge and they're like, you say, what do you feel? And they're like, oh, I feel hamstring tension. You're like, yeah. Do you feel your low back? No. What do you usually feel? I feel my low back. You just drew awareness to a difference. I think that's maybe more appropriate what the, Prague instructors were saying. And again, it's nuanced. I think feeling for IAP is way more important than creating it falsely, because it's probably too much. And, is that going to persist? Probably not. So yeah, that was not mind blowing for me, but it was a good reminder of like knowing that little thing can change everything, right? Of like, oh, that's not our fixed point. Where is T12, or I'd say upper lumbar spine, the actual fixed point? Like, what positions in supine or developmental?
You said the upper lumbar spine?
Yeah. Like L1 through L3.
6 months?
Yeah. So, and that's what I was telling Sloan. I go, when the goal is to create mild flexion of lumbar spine, that's for 6 months, but that's a higher level position. And by that time, you're probably loading up on, elbows for sure, hands. So you're having to control sagittal plane motion more off the ground. So now you have more lumbopelvic control. When you do that, you can flex your spine. You've already started to develop a little bit at lower doses by pushing into extension. But the other thing is, when you're working on that with people, a lot of times you have to assist that, right? It's a hard position to get into. So I remember Dave Juring showing us, like, you're putting the tops of your feet underneath, basically their butt, and letting them sit in flexion, and then playing around with breathing and pressure. And can you remove a foot one at a time? But that gets back into, like, I just remember learning the old SFMA, like 4x4 matrix, where it's like, can it move? Can they move it? And there was a lot of like lumbar flexion drills, because they were always working in this primary movement pattern function of like flexion, or fetal position is like the first position. So you'd actually, if somebody had low back dysfunction of extension and flexion, you'd actually go after flexion first. Just they were trying to create, again, a heuristic. So they have that little, rope walk drill that we do with people sometimes, where you try to flex your spine up, and they do cat cows, and they do standing, med ball stuff. But that's where Sloan kind of started with this girl. She knew she needed to flex her lumbar spine, so she gave her a med ball and had her do basically like breathing walk downs, right, into flexion. And I was like, but you just went to load management technically. You gave her load and you're working her through flexion, and we don't know if she can flex her T-spine, right, at all. We don't know if it moves. And that's, and I'm not calling my wife out here for anybody to listen, like, oh God, they're throwing her to the bus, she's not there. I told someone I was going to talk about this, because it's like, Sloan couldn't answer the question. He goes, I couldn't tell you for sure how well our T-spine flexes. So don't go to the higher order motor control stuff. And again, you can use motor control to help mobility. I'm not saying that, but if you don't know, how do you know if it changed? How do you know what your actually primary like portal of entry or your functional audit, whatever you're going to call it is? But we've talked about that a lot in here of like, just make stuff simple. And I didn't have the option to make, well, I probably made it complex in my head. I didn't have all these tools when I started. So it literally was like adjust, soft tissue, and bird dogs and Stu McGill's big three. So you had to really be on that, because it's like, God, if I can't get somebody to move, like what else am I going to do with them? I didn't have anything else to do with them. Mm-hmm. And I was probably messing up DNS left and right because I was trying to do what I've been taught by Brett in clinic on the fly, but I didn't know all those nuances. So you're just putting somebody in a position and like expecting stuff to change rather than knowing the expected outcomes first. Like we were just talking about, if they can't get their, TL junction down, well, watch what's happening elsewhere. And that's kind of where you're probably working or noticing dysfunction or whatever you want to call that. So any input or other questions on that kind of topic, specifically on like, fixed points, that hierarchy, anything on that? Because what I queued these guys up with before the podcast was like, hey, we had a good conversation last night, Sloan and I. Do you guys have any questions about DNS in particular that have just kind of stuck with you since you've learned it? Like you're like, it's never made sense, or this has never been clear. Because there's lots of things in DNS. The further you go through it, like you'll go to a seminar or something, you're like, oh God, why didn't somebody say it like that the first time? Like numerous things that I went to, and I'm like, I wish somebody would have just said that, because it just was a lot easier. And some of that's language barrier when you learn from certain people, and some of it's just there's a lot, and some of it's just you're not smart enough when you go to take the class, or you don't know enough yet, I guess.
That's more so the one.
Yeah. Well, when you're early, like I said, I got taught from an instructor working on live patients. You like, oh, that'd be the best. That's like learning to, if somebody was just like, hey, I'm going to tell you if this lab values this, just tell them it's wrong. Right? Hey, if this lab values this, tell them this is wrong, and then tell them what to do. And you don't understand like human physiology. And you do that for a couple of years, and pretty soon you're like, when this is wrong, this is what we do. You don't have an understanding. You just got taught like the basic like rules. That's kind of what I was taught. It's like, hey, we get in this position. You want to work on pressure. You want to work on breathing. I don't have all the know-how or the experience. So anything come to mind of other questions in other realms in DNS? And maybe we can take it outside DNS, like conceptual stuff where it's never made sense. I don't know if I'll have the answer either.
Mine would be not necessarily always on just the breathing portion, but how often would you say you try to cue someone on like the movement you're trying to get out of it, instead of letting the, I guess, like movement happen, if that makes sense? Like you put somebody in a position and you're just like waiting to see what happens versus like, hey, I need you to do this, this, and this for me while we're in this position.
And you're saying with their breathing or
So,
overall?
Like overall, I guess. Like if you're, I don't know, like a low oblique and you're really going after somebody's hip. And then like how often are you cueing that versus just like you just tell them, hey, I want you to roll over that bottom hip, see what happens.
Yeah. So I was lucky enough to do a manual therapy course at Rich Olm's house last year. And so it was a smaller group, way more, questions being asked. And towards the end of the course, we all went around the room and said like, hey, what'd you take away from it? What are you probably going to change, or any big, like, mind-blowing experiences? And Rich was like, I'm going to start cueing people way more. He goes, I was under this, because there used to be this guise of DNS of like no talk, reflex stim. It's all manual, like reactions are going to happen, which is true. But then, we were there with Martina and then Robert Lardner was there, and like just cueing all over the place. So my thing is your cues, it's no different. It's motor learning. So how you're cueing is a big deal, right? Drive your knee into the table is not nearly important as a cue to me of, hey, can you get your hip to work? Watch what happens. Do they try to drive their foot into the table? Do they drive their knee into the table? Do they turn more? So it's no different than what we just said with Sloan. If someone's like, hey, I need their T12 down, and then you're watching what happens. So then you got to ask, okay, what's the goal of the position? Well, then if I cue something around that, so let's say Seth said low oblique, let's say it's 5 months shoulder rolling. So they're on their side, their arms kind of out in front of them, like a, pitcher stretch almost position. And we would know, okay, what's the goal of that position? little eccentric load, on the posterior capsule, creating a synergistic kind of action around the shoulder, hopefully offloading the neck. The neck doesn't get too involved. So we could, that's where I give the cue all the time. I'm not telling them, hey, I want you to do this. I'll just smash them to the table. I'm like, hey, can you lift me up? Because the first thing we want is that lateral expansion, right? We don't want them to just like drive their arm into the table. And then you watch what happens. Do they turn their neck on? Okay, well, now I might have to cue, like, what's the cue? Shut this off. Like, I'm fine with that. If they can't do that, then you got, props, which again, if you're motor learning, what's low level stuff? It's device feedback. So if I give them something to like rest their head on, that's not near as important as like, can I get a good pattern while they're, doing it on their own or offloaded? So I think that's a big deal, is like, don't go hard after what you just need to happen. Like, I know I can get it if I just drive your knee through the table, or, hey, resist me. You can do the resist me stuff because that's kind of the manual input, but maybe the better thing there is, if it's resistance first, is don't tell them to resist you, right? Like a lot of DNSs, like think if they're in 3-month supine, you're not like pushing on their ribs and telling them like, hey, let your ribs go down. You're just seeing what happens. If you push on somebody's hip and let's say they give you no resistance or you can't move it, you're also palpating like tone and stuff like that. Mm-hmm. So you could kind of push them for a second. And then if they push back, just like keep going, or like there's lots of ways. But remember, I put out that Instagram post that walked through the phases of motor learning. That's what DNS is. And a lot of it, we try not to give verbal stuff, but like Rich said, like, why not? Like best in the world are doing it more than he was, right? This was a manual therapy course too. It's not like an exercise course. So that's where he was really blown away. He goes, oh man, like we were doing rib cage work and stuff, and a lot of cues with that. So yeah, I'd say quite a bit, but don't go hard and heavy after I need this to happen, so I just go after this. And then also never have the expected you're going to feel this. So I think we're all doing that well in here, of you do something like, hey, what do you feel? Rather than like, hey, do you feel your hip? Like it's that's leading the witness. Like, don't do that. Because you got a lot of people, how many times have you done like sideline, like hip roll, movement, and somebody has pain, right? Yeah. And then the pain's not where their issue was.
Or cramps in the top leg calf, and you're like, all right.
Yeah, or whatever it is. So, what do you feel? I'm feeling, cramp in my upper back, and you're working on their hip. That could tell you something. Maybe that means nothing. I don't know. You gotta, that's information you gotta deal with at that point.
Yeah. That was a very important, I forget when we talked about that several meetings, staff meetings ago, of asking them, what do you feel here versus, hey, you should feel your hip in this position. And I still do that occasionally, unfortunately. But for the most part, I'm trying to think, all right, what do you feel here? And let them tell me, and then decide if that's important to change or have something different.
The thing to reconcile is, so the question out there is, well, what if they feel the wrong thing? That ain't up to you. Mm-hmm. So how do you determine right from wrong or good from bad with a rep? Does it have the desired outcome? Yeah. So let's say, I don't know, like a single leg deadlift. Yeah. Let's just say that. So what would we expect somebody to feel in a single leg deadlift?
Lower than the posterior hip.
Yeah. Hamstring. Yeah, that's what we'd expect. We wouldn't want them to feel probably
pain or
low back, that. So what if somebody's like, I feel my right QL and they're on their left leg? Looks perfect, all that. Maybe they, that's where it gets a little more nuanced, because that's, Greg Rose is really good at this, of everybody's got different input. Some people have different kinesthetic awareness, but also like, why is that thing hard for them? Why are you working on it in the first place? It might not be because they need to feel their hamstring. It might be, hey, what if they lack central stability and they're in a single leg deadlift? Now they do feel their opposite side, like flank. That might be a good thing, especially if it's loaded. So yeah, that's a hard reconcile thing. And that's not a rule. That's just, per case, per scenario, per exercise type thing. But
that kind of came from one of mine, of like, she wasn't good at, like, she has like some hamstring issues that she's dealt with like in the past. Like, well, at least one of my patients said that she had like a hamstring tear at one point. Mm-hmm. So then we started working on like some coronal plane, because she has like terrible balance. So I had her do suitcase carries. Well, this was like right before Thanksgiving, came back and she was like, I was almost down for the count during like all of Thanksgiving, because I was so sore around like my obliques and on like my right QL that like I almost couldn't like touch it. And this is a lady who runs like, 5 miles, like 3 or 4 times a week.
How much weight were you using?
I think I used 20. So it shouldn't have been super heavy. And yeah, she was like, my right side, which is where she has all her hamstring issues on, was just like destroyed.
But there you go. And that's, is that a good thing or a bad thing?
And I only had her go down our hallway twice.
Yeah.
She did it on both sides.
She did it on both sides, and her right one is the one that got smoked.
Yeah. So again, that scenario, I kind of like that stuff because again, soreness now gives you more feedback. You're more aware of that area. I mean, there's all sorts of stuff you can, play around with that. But yeah, I think the more, again, if you layer understanding, great grows would be if you understand motor learning, you can do whatever you want because that's you understand the concepts of all rehab, more or less. That's what we're doing. Then you have to kind of understand physiology to understand tissue demands. Then you understand aerobic capacity. So if you want to be in the rehab realm, you understand those big pieces, I think you do pretty good. And obviously you got to play a little bit of intrinsic motivation stuff. Cool. You got the rehab part down. On table, maybe it's a little bit different, right? There's more palpation nuance there. Maybe less. I don't know. Any other questions like that within DNS realm or?
Yeah. What do we think is happening when, let's say you're looking at somebody in 3-month supine and there's an asymmetrical expansion of intra-abdominal pressure from side to side, and you're able to cue them up to create it uniformly across? One, why do we, what's the mechanism behind why that's only showing up on one side? And how are they then able to change it? Are we contracting half of the diaphragm? What's creating the inability to eccentrically load those muscles in the abdomen on that side? And then how do they actually change it?
Yeah. And anybody listening, I'm not an instructor. I want everybody to think I'm the all-knowing DNS whatever, but in this office I kind of have to because I'm the senior kind of clinician. So these are the questions
the Grays show.
Yeah, we're addressing all the time. No, great question because that's part of the assessment, right? It's you're looking at somebody in 3-month supine from the head. If you're in DNS B, you're kind of oh, there's big valleys there. Or a valley, you're saying on one side. So go back to what we said with what would you see on the glass table looking underneath. So you basically see EOP, a triangle down to the shoulder blades, and then if you cross triangles over to the sides of the sacrum. And then the diaphragm's in the middle with 6 different attachments, roughly different anatomical attachments for everybody. In the middle of your abdomen. So also realize that it's not a contraction game so much in terms of PRI, where we're having a harder time doing, in my opinion, functioning of the diaphragm differently. You said a very good thing of why aren't they able to, let's say somebody had a right-sided inability to create IAP, or they have kind of an indentation around their hip flexor, just more tone. Well, they don't have a great oblique sling stabilization strategy going across there. So that's why they can't let it eccentrically load, because they're in a concentric load to create some semblance of stability.
So you're saying you would expect to see some change in the opposite scapula point of support?
You can't write rules, right? So we have ipsilateral and contralateral patterns. So if we're using a 3-month supine position, so that is a what position?
Ipsilateral. That's bilateral.
Well, it's ipsilateral homologous, right? So it's basically flipped over, you're on hands and feet. When you're there, do you need a lot of oblique control? No, right? Because you should have everything kind of paired up. But if you have dominance on one side, right, you've had an injury, you shut down function, it's just kind of how you play. So you can't say, oh, they have right-sided, it's going to be left-sided shoulder blade stuff, right? That not necessarily, right? Because it could be still ipsilateral, it could be rib cage expansion on the right. Right? They don't have enough pliability. So there's a lot of options, but you're just taking that piece of information and saying, exactly, well, why wouldn't they have it? Well, if I go feel their abdomen and it's soft, that's not a heavy concentric load thing. So that's different than somebody that's braced up and no IEP. These are two wildly different things. So now I can do what? I can change the position, see if the intra-abdominal pressure changes, which is what they were saying in Prague of look for it rather than coach it. And let's say you see it change in a right side lying position.
With that side down.
Yeah. I mean, you can make that a contralateral, ipsilateral position, depending on how you move the top, extremities. Well, you can play around with that a little bit and you're like, man, it's better regardless when they're on their side. Well, that seems more like a right-sided issue. So then I'm looking at maybe rib cage pliability again, can they expand in the lateral, compartment, maybe even their hip, how that plays into it. But and again, you don't have to use all that stuff. But I'm just saying, if there's a single-sided things, would I usually guess there's oblique sling stuff? Yeah, but it could just be rib cage movement that's, unilateral scoliosis, changing symmetry and things like that. I think it's also good to note the difference between a high threshold pattern and a low threshold. They have nothing going on at all, right? Or they're just not able to create pressure because they're so cranked on. Those are two wildly different things. And then we get into all the stuff that they'll teach you in DNS, which it's just likelihoods. So do you remember what you're taught in DNS when somebody has, like, let's say an inadequacy in intra-abdominal pressure on one side? Like, more often than not, that's the side that you're going to have injury or pathology in the lumbar spine. And that's not really research driven that I am familiar with. That's just more anecdotal in the terms of, like, when you're looking at, assessment from a DNS standpoint. Kind of makes sense. Your dysfunction, maybe you shut down. It's like an ankle sprain, you shut down your hip. I don't know, right? Mechanisms, you can make anything plausible. You could also say, well, it's going to be the opposite side, right? I don't know. But that's what you're kind of, or at least I was taught, is like when you see single-sided dysfunction, that's usually the side. But those are the games like, Pavel's playing where he's like, oh, you have lumbar spine. Like, he's just looking at the presentation and kind of making the best guess. Yeah. Anything else on that in particular? Trying to make anything else or any more input on that.
How often are you assessing the rib cage in different positions besides just 3 month? Or are you using that as like your main assessment and then going from there?
Main assess. Honestly, I do it seated. I mean, with almost everybody, I'm having to go hands on head, and I'm just kind of giving them like, I don't even know what those compression tests. They're just checking for
rib fractures.
Rib fractures. Like, I'll do that right away on a lot of people, but then 3 months, and then on their sides. But on their sides is where I start usually working on it, like from manual therapy, whether it's intercostals, just rib cage pliability. 3 months supine, because again, you can do it prone. I guess it doesn't really matter. It's just literally, I think rib cage pliability is one of the easiest things to feel. Then you got to determine, well, what are you actually going to do? You're going to use breathing and manual therapy, just exercise to get that to move better. Is it, we've talked a lot about in here, of is that rib cage stiff because they lack stability on the opposite side? So that's, again, that like posturing around it, like good luck manual therapy in that into a, more mobile rib cage on that side. But going back into the asymmetrical finding stuff, I mean, that the intra-abdominal pressure is no different than if we had somebody in a 4-point rocker test. So hands and knees rocking, and you see one shoulder blade's like massively flared or winged or something, the other side's normal. You can't draw the immediate assumption that like, oh, they have an abdominal, like oblique sling or an oblique sling issue, because you're still right in a homologous position. Yeah. So it again gets back into assessment, taking parts away, change positions, stuff like that. Any other questions in DNS realm, Daniel?
I mean, I feel like my biggest thing is, my own kids. It's like, you have my 1 and 3 could be poster kids for DNS. My middle one, where it's the one, and like every guy wants their son to be a stud athlete. And it just so happens to be the one who was born with like a little bit larger diastasis, who kind of started to drag his leg, but is also the one who, if I'm throwing a ball with my boys, like one of them's going to catch it with his body, and the 2-year-old's going to like reach up and catch it with his hands. And I'm like, of course you are. And then it's like the whole rib cage, like pliability, like we're talking about, like I brought up to you, where, I could see him dragging his leg, and like my weakest point is for sure knowing when and making sure I'm doing reflex stem the right way. And his crawl took longer than I wanted it to, because you want to feel like DNS, so you want it to start, like you want to do it and you'd be like, boom, changed in a week, I'm amazing. And then it really took at least a month where you start seeing it normal. And then and it's kind of like some of the things that were said just about patients in general. I just feel like you see the position, you want to say why. And then so like with him, like I'm in we're in the den like 2 nights ago, and he brings up, because I put the DNS kids poster up, and he was just like, I want to do the bear. And I was like, perfect. And then so like we're doing it, and then like I'm trying to treat it like a game, like we're playing, and then he'll be in a position for like a second and a half. And I'm like, no, buddy, let's keep on doing this. And then he wants to do a different one. So I'm like, okay, because I want to treat it as fun, play, because then he's going to want to keep doing it. And so that's like the biggest one that I'm working on now with him is just rib cage pliability, and then just like making sure any like compensation patterns, because I don't know, you hear anything from like 3 to 5, and who knows if it's even older, but it's like in my mind, I'm like, okay, those are like my age limits where like I want him to be resolved to this before we get to that point, because then it's just all fun from there. But then just always making it fun for kids, because I mean, if you've ever worked with a baby or a kid, they don't love it. And then you're trying to make them do what they don't want to do. And so,
that you and I have talked a lot about Maddox, our oldest, was in the birth canal, like head cocked back into extension and oblique. And then, I mean, not right away, but when she started like trying to lift her head up and stuff, like she literally couldn't. Like she goes into like extension and like had to roll to the side. And I was like, oh, man. And then you were at the course with Brett, and when we had Maddox in there and she was 9 months old, he goes, "Oh, you got a perfectly healthy 6-month-old baby." We were like, "Yeah, she's 9 months old." He goes, you got a variance in there. But that for a long time, I was like, God. So, I was working with her. It wasn't changing. Looking at other stuff. Then she gets collarbone fracture. That adds a little more piece into it. But while I was talking to Sloan last night, the kids were in the living room, and I go, well, look at Maddox. Like, she had this deep neck flexor kind of, whatever you say, weakness, instability. We've worked on it, but then look at her rib cage from A to P is like shrunk down or pretty compressed. You look, she's like upright like this. So she could turn into that person that's got like a scallop T-spine. Mm-hmm. Because why? When she goes to get up off the ground, like she probably has to extend heavily from here and like push her head into the ground, right? So she doesn't have this like clean, like I have a fixed point. What are the fixed points if you're going to get up off the ground? Shoulder blade. And then you can lift your head up and then you could do a crunch. So again, remember we do the kind of Lindau lift test. So she couldn't do it. I mean, her head just, wow. So that's like a sit up. And then little by little, she would go into gymnastics and they do sit ups and they're coaching her. So now I'm like, did she just learn how to compensate well enough that a sit up looks 95% better and it's terrible? Or is it better? And that's, I feel like I don't know everything by it. I feel like I know a lot. And I'm like, I still don't know. With her, like, is it perfect? And then there's no perfect, right? That's the thing. It's not. Is it better? Yeah. Can she get up off the ground doing a sit up? Yeah. Does she choose to still? No. So I just watched her the other night because she's doing like forward rolls or somersaults all the time now and stuff. And like if she goes on her back, well, she'll just roll to the side. And it's like, I don't know, because that's a preference thing. You look at our youngest, who's not even 2. She just literally gets up off the ground like a ninja, and that's different. Yeah. So then again, a lot of people listening, like, why don't you work with them more? It's not easy, right? That's not a cop out. And we still do work with her. I worked with her 2 weeks ago. We were down in our garage working on it. And at the same time, I don't want to be like overbearing with it where they think they have an issue. And yeah, so we just try to make it fun. We look at it. And then if anything got severe enough or she's starting to complain of pain or something like that, it's like, yeah, we're going to go after it. So it sounds like a wait till they're in discomfort, but like nobody is developed perfectly. And maybe there's some, I don't know, maybe you'd be like, oh, isn't that what the best athletes in the world? No. Good kinesthetic aware, you're second, right? Yeah. Got some stuff different, but kinesthetic awareness and athletic ability, whatever you want to call that, which we were just talking about that course, which they're going to talk probably a lot about that at that, what was it? The neurologic approach to athletic development. That's probably what they're going to be talking about is like, well, can we help it? Yeah. Are some people inborn with it? Can you improve those, sensory motor processes? For sure. And that's what we're working on with DNS, not just the mechanics and calming down, trigger points, knee centric stuff. Yeah, you're aware of it for sure. Any other question?
Napa. Sorry, never mind. It's Napa.
Yeah.
Well, sorry, it just looks like it. It looks like it. You tell me that does not look like Nana.
Well, of course it does.
Nana, California?
No,
just
it's
looks like
DNS.
the
Location? Look at the top. It says DNS Nana. That is
yeah.
I mean,
I was wondering what you were saying. I was like,
because the P
yeah,
is like,
okay.
Yeah. Well, Rich will love that you called out his design skills because he'll
please come at me.
Cry himself to sleep tonight.
Well, that's okay. We all need to do that every once in a while.
Any other big conceptual questions outside of DNS where you're like, doesn't make sense? And if you're listening, if you have any of those, like, share it in a comment or something when we share this via Instagram or Facebook or, whatever, write me a letter, send it on a carrier pigeon or something. Anything else?
I just think every DNS course you go to, you just like, what's the why? Try to understand why you're doing it. Like I remember when I first got with Beau, like I did exactly what you're not supposed to do. Like I jumped around to different DNS courses, not necessarily in order. And then some of the basics, once they clicked, and I mean, like, being around Beau every day, like it clicks pretty quickly, but it's like understand the why. Then I think you're looking at different cues. So, I mean, now I think every seminar I go to, my notebook is just filled up with like cues or wording.
And we're talking about DNS. This goes for everything, right? Like diving into Z health stuff, soft tissue. Like I was telling these guys that I think they need to go take an ART class because it helps massively with palpation skills. You have, not that you have to be, you have a legit soft tissue thing to fall back on. Sometimes when you're like, you just need this calm down, it's not. And let's say you're not going to dry needle them. It's a kid and they're terrified of a needle. And, Stecco, you need a bunch of different tools, but also you're expanding your knowledge. And then if you're like, dude, I take the ART stuff, it just doesn't make sense that creating, a slight pressure, moving the muscle is going to calm down a trigger point. I'm with you. That doesn't make any sense to me. But if I'm talking about increased tone in a muscle and a nerve that's running through there and the nerve's irritated, it makes perfect sense to me. Right? Especially if I had a trigger point, come down the trigger point. Now I want to move stuff through there. Maybe that's not a time for neurodynamic. Like you have all these reasons, but then all the concepts need to be questioned when stuff persists, which I've had a bunch of where you're like, that just doesn't make sense. Like maybe they're not right as an option, right? Or maybe you just aren't far enough down the road to have it make sense. But that's what's going to make you better is to constantly ask those questions and get around the right people. And I'm trying to think what I asked. We were watching Pavel work somebody up in the auditorium in Prague, and Robert Lardner was standing in front of me. I asked him, why is Pavel doing that? And he's like, I don't know. And this is somebody who I put on basically the same level. He literally was just like, I don't know. So that's at the same time, not everybody has all the answers all the time anyways, if you think they're best in the world. All right. Speaking of DNS, DNSA, April 4th through the 6th in Nashville, Tennessee. We actually still have an extended Black Friday sale, I think, going till Audra wants to shut it off this weekend because she's mean. I mean, it's going to run longer than that. We'll see. So Black Friday, 20% off with Brett Winchester, DNSA, and I keep wanting to say Vegas, but Nashville, Vegas. A lot of fun stuff going on there. And then we talked about the course, which is July 25th and 26th. They didn't tell me to talk about it. It just looks like a cool course with Rich, Brett, and Alana. That'll be a cool one. And yeah, anything else?
Merry Christmas.
Yeah, I guess this will be the last one before Christmas, won't it? Yeah, for sure. So we'll see you. Well, it'll be the last one for this year.
No, you have one right after.
Right after Christmas.
I will be gone. So Merry Christmas, everybody.
It's on Kwanzaa.
Can't miss that.
And the first day of Hanukkah. I'll have some different costumes waiting. All right. Oh, Merry Christmas and see you this year.
Thank you for tuning in. Please subscribe via YouTube, Apple Podcasts, or Spotify. If you like the message, please share it. We appreciate it. Thank you.